I'm going to introduce Alfonso Wyatt, our facilitator, and he and the other panelists are going to introduce themselves, and then we will start with our curriculum from there. So first, the Reverend Dr. Alfonso Wyatt.
Hello there. As I get off mute, as you heard, my name is Alfonso Wyatt, Reverend Dr. Alfonso Wyatt. I am the founder of Strategic Destiny, Designing Futures Through Faith and Facts, and an elder on the ministerial staff of the Greater Allen Cathedral, AME Cathedral of New York. It is an honor and privilege to be the moderator, facilitator, if you will, of this panel, and also of this important conversation. The fact that the issues, the mental health issues, we see it popping up all over, and it needs attention. So we're going to pay some attention. We have several speakers who will lead us, and at the end, we will be able, time permitting, to take some questions. So it is my privilege to introduce the Reverend Stephen Harding. He's the rector of Grace Episcopal Church. Take the mic, Rector.
Thank you. And good morning, everybody. My name is Stephen Harding. I am currently in Vineyard Haven, Massachusetts. Alfonso, do you want me to go right into the slideshow, or I see that we have some more introductions scheduled?
I will ask you to go into the slideshow, and then as the next speaker, they can do their introduction.
Okay, thank you. So, thank you all for making the time to be with us. What we are going to do for the next 20 minutes is to look at our context that we find ourselves in. I want to tell you what this toolkit does. I want to demonstrate how it can work for you. I want to tell you the four most important things that are in it, and provide referral resources for you. And then, as time permits, as Dr. Wyatt said, we'll answer questions. So if as we go along, you have a question, please use the chat feature, and he will see your question as we go. So I want to go back to September 11th, just briefly, when I was a chaplain at one of the family assistance centers. This is where family members came in to try to get help, to say that their loved one was working at the trade center that day. And one afternoon, I happened to be by the entrance, and this woman came in. And she looked a little disheveled and a little out of place. You know, something wasn't quite right. And I walked up and I said, I'm Stephen Harding. How can I help? One of the chaplains. How can I help you? And she said, I'm here because of my 8-year-old son. He came into my bedroom and told me I had to get out of bed, that I had to get up, and that I had to get help. So here I am. Oh, I said, I'm glad you're here. What exactly can I do to help you? Well, she said, since September 11th, I've been in bed with the covers over my head until my son came in and told me I had to get up. So I asked if I could introduce her to a colleague and walked her over to where one of the mental health professionals was. And I introduced them and I handed her off to that individual. And I tell you this story so that we have a frame of reference for our discussion and for this toolkit, even though it happened September 11th. So normally, a disaster is a single event, like September 11th, and you start out with the event, and then it moves through a sort of predictable response, right? You have the aftermath, short-term recovery, long-term recovery, anticipation learning from this one so that you get ready for the next. And over on the right, this slide that looks like a heartbeat is the emotional well-being, right? So pre-disaster, the event happens, everyone rallies, and then you plunge into disillusionment, and then you work your way back up. That's normal, right? So the woman in my story is located right after the event, probably down around here in this first little dip. But the thing where we are now is that we're in two disasters at once, right? There's the COVID-19 one, and then there's this racism one, the confronting injustice and trying to fix an unjust system. So it's really important, our context, to know where the individual is that we're trying to help. So the thing about this model is that you can be in two different places. You can be right here in the aftermath for COVID-19, but you could be all the way over here for racism or somewhere else at the same time, right? So it's a little, where you are in each disaster is going to be asynchronous in a different place, depending on when each one started for you. So in terms of providing care, right, this heartbeat thing, you know, it could be compounded, and the individual could be so disillusioned that they're like off the charts with it. So you have to know, as a place to begin, where the individual is and where you are too, for that matter. So the challenge for mental health is that all the challenges, all the conditions that existed before COVID-19, they're all still there, but the pandemic has made them worse, right? Everything is now exacerbated. And that's the environment that we find ourselves in with this toolkit. So the single most important thing I want you to remember about this toolkit is that you have to look for time and you have to look for symptoms over time, right? The toolkit is really, it's a toolkit. It provides symptoms, which I'll get into, for stress, normal stress, acute stress, traumatic stress, risk factors for trauma, secondary trauma, suicide, when and how to refer, self-care, and grief. What we're going to look at today is just an example of how to take all the information and apply it. But the thing to remember is time and acuity of symptoms that show up. Normal stress, it's normal. Feeling anxious, lonely, or sad, normal reaction to the conditions of living with COVID-19. But the woman that came to me, her stress response was not normal. And on page 30 of this toolkit, there's a big table with all the stress reactions for cognitive, physical, mental, emotional, and spiritual. That's really helpful. But acute stress, now do you think this woman fits any of these categories? Has her symptom continued for a significant length of time? Yes. Are her symptoms paralleled by an external stressor? Is there something actively going on that made her stay in bed? No. Is she experiencing her symptoms most of the day? Yes. Is her staying in bed with the covers over her head, beginning to affect her ability to care for herself or be in relationship with her son? Yes. All right, so now we have acute stress. Is this traumatic stress? Does she meet any of these categories? Right? The only one that I see is the second to last, becoming withdrawn and avoiding reminders of her experience. But the thing about signs of traumatic stress or trauma is that the length of time, there it is again, there hasn't been enough time yet, because generally mental health professionals need they're looking for 3 to 6 months of the symptom taking place before they are willing to call it traumatic stress. So she doesn't meet the criteria for traumatic stress. But here we come to the third most important thing in this toolkit, which is to know when you're in over your head, right? When you reach the limit of your knowledge, it's time to refer or stop and find someone who knows more about this than you do. I knew with this woman that she needed more than I knew how to help her with. So I did what I could, which was to bring her to a mental health person and say, could you please help, whatever her name is. So knowing your limit is really key. So risk factors for traumatization, I'm not going to go through all of them. I'm just showing you part of what's in the toolkit. But I do want to point out that the first one, the first risk factor, is being part of an ethnic and racial minority group at this time, right? And then it goes on to proximity to sickness, death, and other traumatic experiences. So also at risk is, working with people, trying to figure out where we are on both life cycles of the pandemic, working with family members who have lost people. Storm showed me a text from someone who's doing a funeral for 3 members of a family. I think it was 1 parent, 2 kids, right? We are at risk for secondary or vicarious trauma, which is that through repeated exposure to death, the threat of death, injury, the threat of injury, we're at risk for being traumatized over time, which is why self-care is so important. You have to take care of yourself. And the reason I'm stressing this and secondary trauma is because of these 2 people, right? On the left is Dr. Laura Breen. She was an emergency room physician in New York City. EMT John Mandello had been working with the New York City Fire Department for 3 months. Both of them committed suicide because of their exposure to working with people who had COVID-19. It's real. And that's why we included this slide in there, to bring home the fact that all these symptoms are not just things in a book, but they affect living, breathing human beings, and they can affect us. And there's more about suicidality and how to work with people who are actively suicidal on page 43 in the toolkit. The bottom line on that is if you think they're in imminent danger of harming themselves, like they're actually going to do it right then you call 911 and you explain that you have a suicide person actively thinking about suicide, and they will send a response. Other places, which I'll get to, are the National Suicide Prevention Hotline and NYC Well. But please, take care of yourselves as you take care of everyone else in your faith community. So, this is the next most important thing, is when to refer. And if you remember the second most important thing, that was acute stress. It's the same slide. So when to refer, the recommendation of this toolkit is that when symptoms of stress continue on for a significant length of time and are not paralleled by external stressors, when the symptoms of stress are magnified and or are experienced for most of the day, when symptoms of stress begin to affect a person's ability to care for themselves or be in relationship with others, that's when it's time to think about referring to a mental health professional. And as you go about your work with with the members of your faith community, if any of this is happening, it's time to think about what to do next. How to refer is, you can't just call up Bellevue and say, I have someone coming in. You need to talk to the person involved and let them know that you're concerned about them, that you care about them, and that you think that the best step now is for them to consider a referral to a mental health professional, right? And the stigma of mental health or mental illness during a pandemic, during a disaster, as part of anyone's well-balanced state of being, it's really important. Because if the individual is out of balance, then they are much more at risk for further traumatization. If you have the option, refer people in your congregation to some mental health professional you know or have worked with or trust personally. Start there, talk about fees, location, accessibility. But the thing is that cost shouldn't be a barrier to care. That's why NYC Thrive and NYC Well are making such an effort to reach out to populations who have not historically had as much access to mental health care. And don't let the person that you're referring feel abandoned, right? It's not like, well, I'm handing you off, good luck. It's like you are going to be there with them as part of this. I worked with Rabbi Mordecai Katz at NYU Hospital, NYU Langone. And there was a call from someone who was actively suicidal, and she wanted to say goodbye to Rabbi Katz. And I said, it's Shabbat, and he's not going to answer his phone until later. Would you be able to call back after Shabbat, after sundown, and talk to him? And she said yes. I let Rabbi Katz know what was going on. He went to where that individual was and walked her, brought her to the ER, and sat with her until she was admitted, right? That's the kind of support that is so crucial if you can do it. So that's when, that's how, and then it's where, right? So we talked about calling 911 for someone who's actively suicidal. Here are the numbers for the National Suicide Prevention Lifeline, Domestic Violence Hotline, the National Alliance on Mental Illness, or NAMI, and the Substance Abuse and Mental Health Services Administration, right? So these are national things, but with the ongoing social distance, safer at home approach, I think we're beginning to see increases in domestic violence, substance abuse. So that's why these are in here. But the local one, the one that's more immediately available to New York City, is NYC Well. And there's the phone number, text, chat. It's there. So the fourth most important part of this is where to send people. So first thing is to look at how much time and how acute the symptoms are. The second is to know when and how to make a referral. And the last is where to send them. And know when you're in over your head, when you can no longer be helpful, but you know who can be. So all this and more is in the toolkit. And with that, I commend the toolkit to you, and I'm sending it back to Dr. Wyatt for the next step.
Thank you, thank you, thank you. Like any good toolkit, it should have, hi Franca, it should have a variety of tools. Now, if you come to my house, you'll notice that while I do have some tools, I seem to be disposed to thinking that a pliers can fix anything. So when you go to the tool chest, you cannot just look for a pliers. You have to feel comfortable using the various tools that are there that can help. And some you may use more than others, but given the situation that people find themselves in, that congregants find his or herself in, it's important to make sure. So I want to thank Reverend Stephen Harding for walking us through and to look at those key moments, and especially when to make a referral. And as mentioned, someone asked about the slides. They will be in a PDF. The work of the Interfaith Center of New York, NIDIS, and Thrive NYC, all coming together to provide a resource that is much needed. So with that said, our next speaker, one who heads a renowned house of worship there in on the cusp of Soho and the Village. It is with great honor, great pleasure that I introduce Reverend Donna. She just gave the correct pronunciation, so bear with me. I had it right there, Chapter, and we'll go forth and correct me if you must.
Thank you so much. Great to see slightly all of you. I do proudly correct the pronunciation of my name as Scopper because it's Holland Dutch. And I think if you read the history of New York City, They were pretty good to us for a long time. Not perfect, but pretty good. So bringing us a great history of tolerance and ambition, which is certainly two of the values that we share. I'm really happy to be with you to talk about this important subject, and I'm going to tell a story. It's the best way I know to calm us down and get us energized to use the toolkit, read the toolkit, understand it, and give it to others who may not have the privilege we are having this morning to talk together. So I'm up in New Haven, Connecticut. I left the city on March 23rd. I'm coming back a couple days a week, and it's such a different place. Because I'm up here, I get to play tennis with my old friends. My husband and I met in New Haven, and we've had a place here for a long time. And playing tennis has been a key to our mental health for years. I know it's a funny thing to do, but I don't get to do that much of it in the city. And I played with one new person, not part of our old group, and he did something I've never seen people do playing tennis. He self-soothed. And I got the words out, like you had trouble with scopper, I have trouble saying self-soothed. And most people that I play tennis with just berate themselves. They miss a ball and they curse, they yell, they jump up and down, they use their own name. They say, "Oh, Sheila, you did it again. What's wrong with you, Sheila?" But this man, even older than I am, self-soothed. When he hit a good ball, he patted himself on the back. And he'd rub himself and give himself a little love. And when he hit a bad ball, he would almost get down on his knees and fold his hands up and pray and ask for forgiveness. He was taking care of himself. And that seems to me to be the inner secret to mental health. That much coveted thing that I don't think any of us have all of it, but every one of us has some of it. Even the person who is on the verge of hurting herself this very moment, she probably has some mental health left to say no again this time. So self-soothing is the inner trick. We do have to take care of ourselves. I don't know if we take care of ourselves first, but I think we have to take care of ourselves while we are taking care of others. And the second lesson is about the outer care. You know, you can be as physically fit and mentally fit and as organic in your choice of produce, as friendly with your friends, as self-caring and self-soothing as possible. And if you still live in a racist or a sexist or a homophobic world, it can be really hard to get out of bed. There are outer issues to mental health as well as inner issues of strength. And this is also from the tennis court. I'm playing tennis the other day, singles, with a woman who didn't like how many wet leaves there were on the court. So she kept picking them up and putting them in her pocket. And I noticed that instead of what most people do when there's a wet leaf on the court, we just blow it off our court, right? Get it out of our neighborhood, get it out of our church, get it out of our city. We go localistic. But Sandy picked up the leaves and put them in her pocket so as to prevent other people who might be playing on the court from slipping, me from slipping when I got over to her side. I was really impressed that she did preventive work on behalf of all of us. So I'm going to leave you with this thought. Inner strength must join outer strength. Inner strength must create outer strength so that outer strength can create more inner strength for more of us. Thank you.
No, thank you. And the cycle that you just mentioned enriches itself.
Yes.
And our search, and I believe that this toolkit has the ingredients to geometrically increase one's ability to respond. So what I'd like to do is field a few questions that I have, and then open up. And as you heard, you can use the chat feature if you do have a question or a comment. And we do have a timekeeper, and I understand he's very experienced. He will give me a 5 minute bring the plane in, land it, get it down out the sky, however, and we'll go from there. And again, I want to thank each and every one of you who are on the line, and thank you for the work that you do. So a question that I asked on a previous webinar, I'm going to ask, if you don't mind, I'm going to use your first name, Stephen and Donna, for obvious reasons. If you don't mind, what do you do to take care of yourself, to refresh yourself? If your a bucket, so to speak, is empty, it's impossible to pour into someone else. So how do you reboot? Question on the floor. Any one of you can go first.
Stephen, go ahead.
Okay. I am a big introvert. So I find myself just sitting still, not doing anything, just trying to be for some of the day. I get up early. I'm up at about 5, sometimes even 4:30. And I like that part of the day because it's quiet and I can think and I can say my prayers. And so that's part of it. So quiet, stillness, praying. We're fortunate in that the rectory that we're in has a bit of land. So I put in Hubbard and acorn squash for the fall. And I water those, I weed, and feel guilty that I'm not spending enough time with my family when I have to work late at night.
Okay. Donna?
So about, I'm going to say 2 weeks ago, I had my own mental health crisis. I realized that I was really, if not burnt out, singed around the edges, and really had a kind of spiritual crisis. Since you're not therapists and we don't know each other well enough, I won't go into the details. But it had only happened to me one other time when I also lost hope in my work. I'll talk about that time first. We were organizing on the east end of Long Island in nursing homes, where we had discovered that the nursing homes that kept people of color were not changing diapers, were running the nursing homes to make a lot of money. And we were successful in getting the state to shut them down and take away their licenses, only to find out that they just moved from Riverhead, where we were, down the road to another location on Long Island. Reapplied for a license and did it all over again. And I thought, boy, that's really successful organizing, isn't it? And I took to my bed for about 6 months. I had 3 young children, and through a variety of things, but mostly God saying, oh, come on, Donna, don't be so innocent. I was able to come back and work these 40 some years as a minister. And 2 weeks ago, right before the uprisings, but right after the bird watcher, the jogger, the Minneapolis situation. I know, name the names, but it's so hard. Right after that, I realized I was having that spiral again. It was like, really? What is the point? What is the point? And then, I mean, he doesn't even know it, but Micah, who is the other minister at Judson, said, we have to open Judson and give water to the protesters in the park. We have to help these demonstrations last, be sustainable, not be co-opted, not be used. So the external action of opening a place that had been shut down and my going back down there and taking my stupid spray bottle with its bleach in it and my white cloths and being able to wash the bathrooms as people use them and cry my way through it, I came back. And it's not like we were doing anything big, but we were doing something. And that's what brought me back. And in terms of, you know, like, I do get up early in the morning and pray. I play a lot of tennis. I love to make love to my husband. I love living with him all the time. My one-year-old granddaughter is living with us with her two mothers who are here because the childcare fell through and they both had to work. And so I've got this big family around me and I never have enough internet and it's always zooming myself out. And I've gone back to making a lot of jokes and realizing that I did need the external lift of something happening. I don't think I'd be well if nothing were happening. I don't think I could take it. And that's it. That's it.
Well, there's two interesting intersections that I want to touch on. And one moment similar to what you described, I remember after 9/11,
Yeah.
I was plastered to the couch watching the buildings fall over and over. I didn't realize that I was at the front porch of depression. And the inner voice said, you got to stop looking at this. And it was around this time that I met a woman who was a community psychiatrist. Never heard of a community psychiatrist. But in our talks, one of the statements that she made was the importance of individuals participating in their own self-healing. When you were cleaning with the bleach, you were participating in your self-healing.
Yes.
And that is so important. As caregivers, as clergy, as one folk who take care of others, yes, take care of yourself, and yes, find ways to participate in your own self-healing. Brother Harding, I am an introvert who extroverts well.
So
when
am I.
When I'm on, oh, I'm on. Ain't that right, Franca? Ain't that right? When I'm on, I'm on.
Yeah.
But when I'm off, I'm off. And helping to kind of pull back from all of what is going on and knowing that there's not one person as great, as beautiful, as honest, as trustworthy as you are. There's not one person in one of these boxes that have the answers to all of the problems. So with that said, what message in the toolkit resonated with you? If you could pick one message in the toolkit, which one message resonated with you? And I'm going to push because I'm looking at my host, and he can communicate with me and go from there. Yes, either one of you. What message in the toolkit resonated? The mental health toolkit resonated with you?
I'm just back on the task, right? When in times of high stress, the story I'm thinking of is a guy that was on a solo camping trip, broke his leg, and was like 10 miles from anywhere. And no phone. And the first thing he did was to sit down, his legs broken badly. He sat down and made himself tea. And that calmed him down so that he could think and plan, and he got out safely. But his first considered action was to do a mechanical task. Could have been self-soothing, but it just gave him the space, and it lowered his heart rate and blood pressure to the point where he could actually think and work out what to do. And he got through it. The important thing is that, for me, having lived with this now for a while, is that it's like a doorway, right? It doesn't pretend to be mental health, but it's helpful for faith leaders in understanding how to, it's not move people along, because that's the wrong language, but it's how to open that door for them so that they can go through and get the help that we as faith leaders focused on spiritual well-being are not as trained in mental health well-being.
Okay.
But it's the doorway for us to help people to go through.
Okay. Don, I'm going to get you, and then I'm going to ask Peter if he would just be cognizant of any questions that may show up in the box, or we may go another route. Don.
Completely agreeing with Stephen about the lack of mental health training amongst we spiritual practitioners. And without being pugnacious unnecessarily, I think the opposite is also true, that often mental health people aren't able to unlock that door of the great spirituality that lives even in the unchurched, the unbeliever. That there is spiritual power in healing. And I think that finding ways to work back and forth on both diagnosis, science-based thing, all of these things, and the spiritual power seems to me to be very important.
Okay, thank you. Peter? You're on mute.
I need to unmute. I just want to make sure everybody has the opportunity to ask any questions they have. If you could write them in the box, in the chat box, that would be helpful. We certainly want to make sure to thank the Interface Center, Chloe Breyer, executive directors on Zoom. I forget what phones are like. They're like antiques now. Who's been our partner in this effort, and Thrive NYC, which funded it. But the toolkit is meant to obviously be something that can support all of us in our congregational relationships and caregiving. So please feel free to ask questions if you have them about what you've heard, perhaps something that you've read in the toolkit that you would like clarified. Are there any questions anyone would like to ask? Because you're free to unmute and ask at this time.
calendar for mental health activities. There's a section on moral injury, grief and complicated grief, self-care. We tried to be pretty comprehensive, as well as more resources and tips.
Thank you. So Storm asked a question about how religious leaders share the toolkit with members of your faith community. Obviously, from the title, the toolkit was written as a resource for faith leaders and community leaders, but I do want to say there is the front section of the toolkit is an evergreen toolkit, meaning it's meant for all time use, not just during the pandemic, which is the section that we helped create. And there is an enormous amount of information in there that I do think is helpful to anybody who is working as a caregiver or simply as someone in relationship with other people in their own families. Part of the challenge I think that faces us during times of crisis like this is that we sometimes want to normalize abnormal behavior as a way of avoiding confronting what we see as people struggling with the trauma. And given what we know about mental health and some of the challenges around accessing help, you know, the disturbing statistic of the average person doesn't seek mental health support until they've been experiencing signs or symptoms for almost 10 years. That is a distressing statistic, to think that there are people in our life, in our congregations, as Christian leaders that we know that have been suffering or perhaps just misunderstanding the signs of mental health distress in themselves and don't come forward for up to 10 years, means there's a lot of people around them that have not been observant and not been willing to talk about those signs or symptoms. And I think we can do better at that as faith leaders. How do we live in community as caregivers and reconcile that people are in crisis for extended periods of time before they come forward? I do want to circle back on this kind of double-layered crisis of the moment, however, and how we look at this toolkit as a resource. How do we confront systemic racism, which is tearing apart the fabric of the African American community and communities of color yet again, where those communities are crying out for help, at the same time that we have seen communities of color and Black communities in particular disproportionately impacted by the coronavirus. So what does it mean to be a faith leader in a congregation that has people of color, or that are predominantly congregations of color and led by leaders of color, during a time in which there is extraordinary vulnerability to being a person of color, a lot of stress and trauma, and how do we as faith leaders address that in a way that looks at the challenges we face as ongoing? We have to accept the coronavirus as a virus is going to be with us for at least another year. Many people predict longer than that. And at the same time, we have seen, for whatever reason, I have personal ideas, we've seen the Black Lives Matter movement finally gain traction beyond one or two news cycles, where the protest movement has made a significant difference in exposing racial inequities and inequality in our society, police brutality, in a way that people are paying attention. And how long will they pay attention? And will it be long enough to create systemic change? Because I'm sure many of us doubt that, that it's working, but how long is it going to work? and will change come? So those are some of the things that are on my mind as we have this conversation today. Bonnie Black was raising the challenge of using the word normal versus typical, which I think is important when we talk about mental health challenges that we face. What is normal is hard to define. Normal is different for everybody.
I would like Bonnie, if you're there, if you would elaborate.
Sure, that'd be great.
Yes, because when, and I'm not only a layperson, very active in our congregation, but also a mental health professional. When you say, well, a typical reaction could be, people hear, they listen. But if you say, oh, well, a normal reaction, that almost shuts people down from actually digesting everything after that in a sentence, because nobody wants to be abnormal. But typical, well, typically in June, we can get into the high 80s here. Well, that's a fact, that's okay. So typically, you know, when adolescent girls